Good morning, class. Today we'll discuss about the approach to the patient with dizziness and vertigo. I am Dr. Bhupendra Shah, Assistant Professor of Department of Internal Medicine, B.P.Koirala Institute of Health Sciences. This lecture is basically for the 9th semester MBBS student. So what we are going to discuss in today's lecture will define what is dizziness and vertigo. We'll discuss about the etiology of the dizziness and the vertigo. We'll discuss about the clinical presentation and how we can make the diagnosis of the dizziness and vertigo in today's lecture. So what we call the dizziness in vertigo? In Nepali, people say, doctor, I'm having chakkar. Some patient might say, I'm having gurmi lageko, like that. But when someone say, doctor, I am feeling dizzy, it may be vertigo, it may be disequilibrium, it may be presyncope, or it might be just a non-specific dizziness. The etiology of the vertigo, presyncope, disequilibrium, and non-specific dizziness are different, and management also differs. That's why we need to know what our patients exactly mean by their dizziness, if they are complaining the dizziness. So these terminologies like vertigo, presyncope, and disequilibrium and NSD are not the diagnosis, are not the exact etiology for the dizziness. We need to know, we need to work off for the etiology of this condition. So what is vertigo? If someone say, doctor, I am having illusion of motion, then that's the vertigo. Like my surroundings are rotating, or myself I'm rotating. Then if someone say like that, then that's the vertigo. So the important component to define the vertigo is there should be the illusion of the motion. It's usually short lasting, like short lasting, and it's usually intermittent and usually get aggravated by different change in the head position and usually associated with postural instability and the nystagmus. So in your day-to-day life, we all have experienced the vertigo, like in our childhood, like when we play the game where like if someone is like rotating us by like rotating us, in that scenario, like we may feel the vertigo. So vertigo are never long lasting vertigo. It's usually the short lasting, and like it usually get aggravated when it moves our head or when we change our body position, like when someone is like standing from the sleeping position, or when someone is like taking right decubitous to left decubitous position. In that conditions we can get vertigo. So as the vertigo, if someone is having the vertigo, it's usually because of the disease of the vestibular nerve, brainstem, or cerebellum. So patient might have the features of the hearing loss or other brainstem signs. The second terminology we need to know is the presyncope. Presyncope is the prodromal symptoms of fainting and near faint. Okay, like classically when we see the patient with certain cardiac disease, like classically aortic stenosis, or sometimes in mitral stenosis, or the person with low ejection fraction, or if someone is taking the antihypertensive. Okay, and if someone is having the diarrhea and the vomiting and that volume loss, it can cause the presyncopal state. The patient feel dizzy when they take the standing position from sleeping or sitting position. Like when someone just stands and just they feel like as if they are going to fall. That sensation is called the presyncope. That sensation is called a presyncope. And it usually occurs for seconds to minutes. So if someone say, doctor, I am having the feeling of dizziness when I am taking the standing position from the sitting position, then that's called the presyncope. In that scenario, you have to take the history regarding the cardiac disease, regarding the antihypertensive intake, or regarding the fluid loss or blood loss. Okay, that's the presyncope. It's totally different from the vertigo. In the vertigo, it can occur in any position. It can have it has the illusion of motion. Whereas in presyncope, this is just a feeling of as if our patient are going to fall when they take the standing position. Then that's the presyncope. Look at the etiology. In vertigo, most of the conditions, the etiologies are related with the ear, brainstem, and the cerebellum. Whereas in the presyncope, etiology is more related with the cardiac disease or blood pressure, low blood pressure. Okay, look at the etiology. Then third terminologies that we need to discuss is the disequilibrium. Okay, disequilibrium. It's a sense of imbalance. Sense of imbalance. When patients are walking, they feel that as if they are going to fall. Okay, as if fall. Here, the one condition is the one walking only. It occurs if the patient is having the neuropathy, like usually large fiber peripheral neuropathy, or musculoskeletal problem like myopathy, or sometimes in the bilateral knee osteoarthritis. Especially these conditions occurs in the elderly populations when they start walking because of the concomitant presence of neuropathy or different musculoskeletal disease. They can have the feeling of the imbalance. They feel as if they are going to fall, and it occurs only on walking. Okay, so it's quite different from the presyncope and the vertigo. Okay, and the fourth one is non-specific dizziness. When I sit in the neurology OPD, so many person comes with this picture. Doctor, I'm having dizziness always, like sometimes it get relief, but like when I'm walking, when I'm sleeping, when I'm like thinking, I feel I'm having dizziness. मलाई सधैँ चक्कर लागिरहेको जस्तो अनुभव गर्छ. So these conditions have usually the fluctuating course. When the patient are relaxed, then like there is no like history of dizziness. When they are in stress, when they think, when they are alone, then they can have dizziness. And usually this condition is related with the psychiatric disorders like anxiety and depression or other somatoform disorders. And the common age group for this presentation is the adult male or female. Okay, adult male or female. And it's usually chronic, it's usually persistent. Despite giving the medications for the dizziness and the vertigo, like if we are not able to diagnose these conditions, underlying anxiety or underlying depression, then we are not going to cure this condition to the patient, and this is so problematic to the patient as well as the treating physician. So we have discussed the four issues here. One is vertigo, where there is illusion of the motions, usually as maybe associated with the nausea and the vomiting, vertigo. Secondly, presyncope, like feeling of dizziness on standing position. Third one is disequilibrium, feeling of dizziness on walking, usually associated with the neuropathy and the musculoskeletal problem. And fourth one is the non-specific dizziness, usually associated with the psychiatric disorders and the drug intake. is usually the like chronic and the fluctuating cause. Okay. So don't write every case as a vertigo under evaluation and like that. Okay. So like these are the quite different, and you have to listen your patient carefully, so that only you can write the proper diagnosis. Okay. So let us discuss more details about the vertigo. So what is vertigo? We had already discussed the vertigo is the symptoms of the illusory movement. Illusory movement is occurs because the input from the vestibular system is asymmetry. If there is similar input from the both vestibular symptoms, then we may not feel the vertigo. But like if there is input from vestibular system to the brainstem and the cerebellum is different, like if there is imbalance between the input from the right and the left, then we can feel the illusory movement, and that's called the vertigo. So how we can say it's a vertigo? The number one characteristic is spinning quality. Like spinning quality is usually never permanent. If someone said, "Okay, I'm having this vertigo since like 1 month, I regularly, like there is like no time that I'm not feeling the vertigo." If someone say like that, then that's not the vertigo. That's like more suggestive of the NST, non-specific dizziness. Vertigos. When someone is having vertigo, then these symptoms get aggravated on head movement and may occur even in resting state. Okay. So what are the causes of the vertigo? The causes of the vertigo are that there are some peripheral causes and some central causes. But in our day-to-day clinical practice, I got the BPBB, that is benign paroxysmal positional vertigo, as one of the important peripheral cause of vertigo. So it is usually of intermittent type. Okay. Whereas vestibular neuritis usually present acutely. If someone has acute vertigo, then one of the important disease vestibular neuritis. Third one is Meniere's disease. It's also associated with other symptoms like sensory neural hearing loss and tinnitus. It is also the chronic type on and off symptoms. Okay, earfulness. It's also the important cause of the vertigo, and sometimes it may be this is a feature of acoustic neuroma, which occurs commonly in elderly population. These are the common cause of the vertigo. What are the central cause of the vertigo are like migrainous vertigo. Like I see like so many patient, like female patient with like, "Doctor, I'm having vertigo," like that. It may be just a migrainous vertigo. If someone has the acute onset of the vertigo, then one important disease are brainstem ischemia and cerebral infarction. If I'm all right, then if I'm suddenly having vertigo, then that maybe just a feature of the cerebral infarction. That's why we have to think about the cerebral stroke. And sometimes even in case of multiple sclerosis, it can cause the vertigo, especially in female population. Okay. Then we know the peripheral and the central cause. Then we have to know whether it is the first episode, single episode with a recurrent type. If someone has a recurrent vertigo, then it may be the BPBB, Meniere's disease, and the migraine. Okay, doctor, I am having this type of vertigo since so long. I had a history that 1 month back I had similar episode of vertigo for 2 to 3 days. Now I am also having this type of vertigo now. Then it may be BPBB and Meniere's disease. The BPBB is it's usually like with the head movements there is a vertigo. In Meniere's disease there is other associated features like sensory neural hearing loss, ear fullness, and tinnitus. So we have to ask these all history. In migraine there is concomitant headache. If someone is having the new onset vertigo, then we have to always think about the vestibular neuritis or cerebral infarction or the brainstem infarction. Okay. Definitely we need to differentiate whether it's the peripheral cause of vertigo or central cause of vertigo. Peripheral cause, whether it's the BPBB, whether it is a Meniere's disease, or whether it's a vestibular neuritis, or whether it is the like central cause like cerebral infarction or brainstem infarction like that. So in the peripheral cause, there can be the nystagmus, but it's usually unidirectional towards the lesion. It's usually horizontal. Okay, and it's the suppressible. Like if you can suppress that nystagmus if you fix your gaze, then you can suppress that nystagmus in peripheral cause. Other peripheral symptoms like deafness may present, the hearing loss may present, and definitely patient can stabilize themselves and can walk in peripheral cause. Whereas in central cause, this nystagmus can have this jerky movement of the can have can take any direction, like it can have like vertical direction, it can have horizontal direction, some it can be like rotated directions. So in the central case, the nystagmus there is like it occurs other than the horizontal directions, then it may be the central cause. The nystagmus that is present is quite severe and it's not suppressible. And usually the sensory neuritis are usually not present and they have severe vertigo, even they can't walk. Okay, in case of, I see the so many patients with cerebral stroke. When they say, doctor, I have vertigo, then I will ask them, can you stand? Usually they say, no, doctor, I fall when I start walking. This type of history will be of cerebral stroke. If patient can walk even with vertigo, then we have to think of peripheral cause. If a patient can't walk with vertigo, then we have to think of central cause, because we have to plan differently when you are thinking the peripheral cause and the central cause. Like in the central cause, then we definitely have to do the MRI of brain. In the central cause, in peripheral cause, we have to think about, we have to work out for the other, it is by doing the test like PT, pure tone audiometry or hearing assessment like that. Okay. Then the symptoms of vertigos are like, other than the illusion of motion, they can have nausea and vomiting. Most of the patients say, doctor, I feel nauseated when I'm having vertigo. They have gait instability. And the vertigo for the BPV lasted for less than minutes, whereas vestibular neuritis, it can last for days, and cerebral infarction, it can last for weeks. So depending upon the duration of vertigo, the etiologies are different. Okay, aggravated by head movement. So what are the tests? Like if someone has the vertigo, then what are the tests we are supposed to do? We are supposed to test the important is nystagmus testing, because nystagmus is quite common in case of the peripheral as well as the central cause. Presence of nystagmus always like point out towards the vertigo. In the peripheral cause, when there is a nystagmus, jerky movement, it is suppressible. In central cause, it is not suppressible. So we have to see whether nystagmus is suppressible or not suppressible. Then we have to see the direction of the nystagmus. We have to also grade the nystagmus. For that, one person is looking front, then you can see the jerky movement. Then you have to move your fingers right side and to the left side, and you have to see the jerky movement. Okay, that's how we can see the nystagmus, and we have to write the direction. We have to write whether it's suppressible or not. We have to write the grading of the nystagmus when you're evaluating the nystagmus. Definitely, we are supposed to check the gait instability. And when there is a gait, patient is having the gait instability, then we have to definitely think about the cerebellar cause. Definitely, we have to do the hearing test, because if there is a vertigo along with sensory hearing loss, then it may suggest it may be suggestive of Meniere's disease or sometimes the acoustic neuroma. That's why we need to test. And Dick-Salpike maneuver is a test that we are supposed to do because it can diagnose the benign paroxysmal positional vertigo. So please do Dick-Salpike maneuver. Okay. So this is the like what I'm trying to show. This is a video, but but I cannot show you the video here. This is the basic screening test for the vertigo. If someone is, this is head impulse. What you have to do, you have to just, when patient is looking, then you have to just give the impulse to the head from this side. Just bring the head to the straight. And you have to see whether there is a latency in the movement of the eyeball or not. If there is a latency in the movement of the eyeball, like if eyeball takes some times to come to the front, then it's positive, and it's usually the seizure suggestive that the cause of the vertigo may be the peripheral cause or the central cause. So please do the head impulse test. So other test we have to perform is the Dick-Salpike maneuver, and we'll discuss later on when you are discussing the cranial nerves. So my take-home message for today's presentation is, when someone complains you about the dizziness, doctor, I'm having dizzy, then don't write it. All dizziness are not vertigo. Try to find out what your patients are trying to tell you is this vertigo, whether there's illusion of motion or not, or whether it is a presyncope, that patient is having dizzy on a standing position, or whether it is a non-specific dizziness, chronic, persistent type of, mild type of dizziness, or whether it is a disequilibrium. You need to listen. You have to listen that thing. Then your approach will be different. Examine the patient. If you see the nystagmus in the eye, then it's usually a vertigo. When you are looking the vertigo, you are confirmed that it's a vertigo. Then you have to differentiate whether it's the peripheral cause of vertigo or the central cause of vertigo. The important peripheral causes are, as we have already said, BPBB, main and acoustic neuroma. The important central causes are like cerebral infarction, brainstem infarction, like that. So we need to differentiate. And we should always consider non-specific dizziness if the symptoms are constant, persistent, if patients are complaining, and if they are not responding to your usual treatment. Okay, thank you so much for your kind attention. If you have any problems and any queries and any comment in this lecture, then you can write in the comment section. Thank you.